I'm Dr. Shreyash Gajjar, working at Kokilavin Dhirubhai Ambani Hospital in Mumbai. This is a video demonstration of an all-inside ACL reconstruction using an internal brace. We have noted from recent literature that when we have moved to doing an anatomic type of technique, there is a high forces which subject higher incidence of graft retear, and therefore if one does not get an adequate graft, or if we have an above average BMI patient, then reinforcing with an internal brace is quite useful, and this surgical technique demonstrates the same. So firstly, the semity is harvested and a graft link type of preparation is done as would be done as a standard technique. The semity is quadrupled and feeded on either side of this adjustable loop device on the graft master, and the tape is then feeded through the femoral side of the button, and the free ends are passed between strand 1 and 2 on one side and strand 3 and 4 on the other side, to ensure that these tapes are buried within the graft and they do not stick out into the joint. The free end of the tape is kept loose and the graft link sutures are tied, and you can see that you can slide it easily. So on the arthroscopic view, the right knee, the femoral side is identified, anatomic position localized, and the triangular drill pin is used to create a desired depth. In this case, it is around 40 millimeters. Um, After this, a depth gauge is used, which confirms that it's actually a larger tunnel, 45. And then on top of that, a low profile reamer is used. Because this involves creating sockets and not tunnels, and we are expecting around 20 millimeters of graft on either side, I typically drill 5 millimeters more on each side of the socket, and on the femoral side, this tends to be 25. The sharp edges are then rasped to prevent any graft impingement on the femoral side. On the tibial side, the footprint is identified with this jig, just a touch anterior to the footprint of the ACL and the lateral meniscus anterior horn. And the flip cutter device is then passed of the appropriate diameter, and retrograde drilling is done, as you can see here. And that is done to a mark of approximately 25 millimeters. And the stump is preserved, and it's important to clear these sockets to prevent any graft impingement and easy passage. So this completes the tunnel, and then a retrograde suture is passed through the tibial socket and retrieved through the low anteromedial portal as seen here. And then subsequently, in a standard way, the suture is passed through the femoral socket with the knee flexed to 120 degrees, as was done while drilling. So that there are two different color coded sutures, and there is no impingement, as you can see, because the graft is passed through the anteromedial portal as seen here. So the adjustable loop and the tapes are being retrieved on the femoral side, and the sutures mark the 20 millimeters into the femoral socket. And then subsequently, these sutures are railroaded through the tibial socket. All this graft patch is done through the low anteromedial portal. As you can see here, these sutures on the tibial side are being passed or railroaded, and that completes the passage of the graft. It is still not fixed, and here I'm going to demonstrate that the tapes which we have used to reinforce it as an internal brace are buried within the portion of the graft. As you can see here, that's one part of the tape, and that's the other one. So they are buried within the substance of the graft. And then fixation is done on the either side, and I will just talk you through the sequence for that. So on the tibial side, with the knee around 30 degrees, the cortical fixation is done, and the internal brace is fixed separately with the knee in hyperextension as a normal side with the help of a knotless anchor. As you can see here, this ensures that the internal brace acts as a check rein and does not over constrain the knee. The extra ends are dissected, and then in around 20 degrees of flexion, the tibial side is tied, and then the femoral side. And the knots are tied so the loop becomes fixed. As you can see here, they are nicely buried within, and the internal brace is lax. It is not constraining the knee. This is very important, differential tensioning of the graft versus the internal brace, to prevent any stiffness at any any case. So at the end, a standard ACL rehab protocol is followed as one would do. And this type of technique ensures that the concerns of graft failure, especially with this anatomic technique, are almost negligible or really minimized.